and hit record.
Okay.
All right, go ahead and introduce.
All right, everyone. Today it's my pleasure to introduce Dr. Philip Tipton from Mayo Clinic, and he's currently finishing up his fellowship in movement disorder. And let him take the floor.
All right. Thank you, Fadi, and thank you, Elizabeth, and everyone that was involved in organizing this. This is really a neat program, and I'm glad to be a part of it. I should preface everything with a little apology. I'm getting over laryngitis, so my voice is kind of coming in and out. So I'll be slugging on my water as we go, but we'll get through it. All right. So I am excited to present a case to you that's really some bread and butter neurology, and it's a case that at the end of your medical career, no matter what specialty you go into, you will have heard this case before. You will have seen this patient multiple times, and you may even be managing their symptoms, regardless of your specialty, whether it's neurology or something else. So we'll dive right into it. The patient is a 65-year-old gentleman, and he presented with a 2-year history of tremor involving his right hand. And some other things that he mentioned in the history is that he had noticed a change in his sense of smell 10 years prior. Probably can't blame it on COVID. And he's also had some emotional changes, maybe a little bit more down than he used to be, maybe a little bit more fatigued. No hallucinations, though. And he had a past medical history that was notable for high blood pressure, high cholesterol. He has some acid reflux, and his surgeries included a right rotator cuff repair and an inguinal hernia repair. And so his medications, as no surprise to you, would include lisinopril, simvastatin for the cholesterol, and pantoprazole for his acid reflux. His family history included an aunt who had a tremor, no diagnosis of Parkinson's disease, but a tremor. And on his mom's side, there was a relative that had Alzheimer's disease, and she developed symptoms in her 70s. His social history is underwhelming. He has, on average, he would drink a couple of glasses of red wine per night. And he had noticed that actually smoking marijuana helps with his tremors. So from time to time, he would smoke marijuana. And he's a retired farmer. On his review of systems, there were some other things that came out that didn't just come out in the history, and that included constipation that he'd been dealing with for about 4 years. And this was pretty severe sometimes. In fact, he even went to the emergency department once because he had gone for 5 days without a bowel movement. He also has a longer history of erectile dysfunction, and his wife had noticed some movements during his sleep. Yeah, we'll kind of hold off there without going into any more detail. And those have been going on for about 6 years. I asked about cognition, and there really weren't any concerns on the part of the patient or his wife, who was joining him for the evaluation. So I'm not sure how you typically do it, guys, but I wonder, this is sort of a framework of a history. I wonder if anyone on the call has any questions about the history before we go on to the next step.
So if anybody has any questions, go ahead. Feel free to pop it in the chat, or go ahead and unmute yourself.
I'll start it off, Phil. So this is just from prior knowledge. I was always wondering, so the changes in smell, I always was curious about that. Like, I've heard rumors that their smell is more expressive for like grease, if that makes sense. Like, they can smell grease better and stuff like that. Like, it's more so I've read a study actually where people were able to, who had Parkinson's, were able to smell grease, if that makes sense.
Mm-hmm. Yeah, I'm not familiar with that specific study, but yeah, as far as particular smells that are able to be smelled,
Yeah.
specific odors that are able to be smelled. I don't know how specific that is for Parkinson's disease. We have a few ways of testing it because, as you guys know, I mean, there are lots of folks that don't have a great sense of smell. Like right now, I'm getting over a cold, so I don't have a great sense of smell. Lots of folks have allergies. And some people will tell you, yeah, I've never had a great sense of smell. Or their spouse will say, yeah, he's never had a great sense of smell. And that doesn't help you all that much. But, you know, if you find something that's been a change, that can be pertinent to the history. And so in the case of this gentleman, there was a change. And, you know, honestly, very rarely are people going to say, yep, 10 years, that's when my smell went away. But because it's usually more of a gradual type thing. But I find in the way that we would get it in this history is asking people about their day-to-day life. You know, would you be able to smell it if something was burning in the kitchen? Or, you know, are you able to smell fresh flowers? Or coffee is a good one. Coffee is even one that you can kind of test too when you get to an exam. Or peppermint, those types of things, you know, sort of characteristic aromas, fruits like oranges, those types of things. Those are nice things to kind of get a handle on whether or not smell is impaired. And then hopefully from the patient and whoever joins them, you can kind of nail down how long it's been going on if that's the case. But as far as specific aromas being specific to Parkinson's disease, if that's what we think this is, then I'm not sure of some specific ones.
Okay.
Good question though.
Yeah.
Any other questions? Maybe anyone that has a shelf exam coming up on in neuro. All right. Well, one that I might have if I was in your shoes is why are we mentioning anything about movements in the sleep in the review of systems? And so, you know, a lot of people move around in their sleep. Some people have, you know, jerks as they're falling asleep. Some people even have muscle jerks when they're waking up from sleep. Those are actually pretty normal things. I don't know if any of you have ever seen that. My dog actually moves around in his sleep and makes jerks too. So I get to see that every day that he goes to sleep. But what this person's movements were a little bit different. They're not just muscle jerks. They're not just kind of rolling over to reposition because you're a little bit uncomfortable in your sleep. This person was actually making complex movements in their sleep. In fact, punching and kicking in their sleep to the point where his wife was waking up with bruises. And that's how it came up. It came up in the conversation. And so when you hear about that, it's very unusual for someone to move around with complex movements in their sleep. And so one way that you can kind of dig into that a little bit further is asking someone's bed partner if the movements match the dream. So can you kind of tell what your bed partner is dreaming about by looking at their movements? So whether it's punching or playing basketball or fishing or something like that, because what it is actually indicating is that there may be an abnormality in REM sleep. You know, in normal REM sleep, and you guys have probably gone over this in your neuroscience course, but normally during REM sleep or rapid eye movement sleep, all of our muscles are paralyzed with the exception of a few. Obviously, your extraocular eye movements aren't paralyzed because that's why your eyes are able to move rapidly. And your diaphragm isn't paralyzed because you've got to be able to breathe. But otherwise, your muscles are paralyzed, and that's because that's the stage of sleep when you dream. And so you can think about from an evolutionary standpoint, it's probably not the safest thing for you to be acting out your dreams. What if you were running from a lion and you did that while you were asleep, ran out into traffic and got hit by a car? You know, that doesn't make much sense. So fortunately, we have a very elegant mechanism that is predominantly involving brainstem structures that keeps our skeletal muscles paralyzed during our sleep. Now, there are some conditions where that mechanism can be adversely affected, and we're not paralyzed during our dreams, and we get dream enactment behavior. And so we actually call that REM sleep behavior disorder. So you can't make a diagnosis of REM sleep behavior disorder from the history, but you can come to a conclusion that someone's acting out their dreams. And so you kind of put that in your back pocket when you're thinking about your differential diagnosis. Okay.
So I had one question also.
Yeah.
Just regarding the social history for the retired farmer, any interaction with pesticides?
Oh yeah, definitely.
Okay.
Definitely. Good question. All right. So let's move on to the physical exam. His vital signs, seated, were normal, nothing surprising there. We noticed when we talked to the patient that his voice was a little bit soft, and his wife didn't really mention it, but we noticed it. And his facial expression seemed a little bit flat. So his what we would think of as a happy face didn't quite seem super happy, and super sad faces didn't seem super sad. And his blinking rate was a little bit slow. It almost looked like someone kind of in a daze at times. His cardiac examination was unremarkable. And his pulmonary, a brief pulmonary exam was unremarkable, as was an abdominal exam too. On the neurological exam, though, there were some things that were definitely worth noting, beginning with mental status. And I should say that, as I go through the neurologic exam, there's a lot of ways that one can organize their neuro exam. But as you know, it's a very complicated exam. And so it's very, very, very important, critical, in fact, that you develop a system. Because there's so many things, it's just too easy to forget something. So if you have your system, you always know if you miss something. So it's the same way that you guys probably have systems for reading x-rays or reading an EKG. You've got to run your checklist so that you don't miss anything. Okay. And of course, you tailor your examination based on what you're looking for, but at the bare minimum, you always need to have a neurologic screen, because you don't want to be, you don't want to miss things. Okay. So the way that I like to organize my exam is beginning with the mental status. And a lot of this you actually get from your interview with the patient. You, depending on what you find, you may have to dig in further, but we didn't find that need with our patient. And so suffice it to say that he was alert, he was oriented to person, place, time, and situation. He knew who his wife was, he knew who the president was, where he was, what day it was, the date. And because we were able to converse normally, he understood what I was saying, I understood what he was saying. There wasn't any overt evidence of aphasia. During the examination, I'd ask him to use his left or his right hand. He was always getting that correct. He was consistent. And we checked for apraxia. Excuse me. We checked for apraxia. Now, I mentioned that in this exam. I'll come back to why it's important in this exam, but the way that, well, I guess I should define apraxia first. Is it inappropriate to ask questions on this forum?
No, of course not.
All right. So does anyone want to say what apraxia is while I grab a cough drop? Anyone know?
Is it like making purposeful movements, like very deliberate movements?
Yeah, you're on the right track. You're on the right track. Anyone else? Okay. So apraxia. Yeah.
Sorry, no, I was just a little late on that, but I was gonna say, is it when you can't follow a command on like a movement command?
Yeah,
Like
each answer is getting closer. It's getting closer. So apraxia is the inability to perform a learned task. Okay. So Raul, you're right that it is sort of a command. You kind of have to have a command. But let's say someone asked me to make the peace sign with my fingers. That is a complex motor program to be able to do that. All right. But let's say I've got, carpal tunnel, bad carpal tunnel, and my fingers are weak. I'm going to have a hard time doing the peace sign, right? But does that mean it's apraxia? Well, no, it means you've got weakness. So what about the person that has no sensation in their fingers? You know, they don't know where they're at in 3D space, and you ask them to do something and they're not able to do that. It doesn't mean that it's apraxia. It means that they have severe sensory loss. So you can't determine whether someone has apraxia unless the fundamental elements are working properly. So strength and sensation and some other things as well. But apraxia is really the inability to do a previously learned task. So a few ways that I'll test for it in my examination is, excuse me, guys, is asking patients to mimic gestures. So a peace sign, or, you know, whatever that sign is. Be careful with the signs that you use. I've learned over time from people in different cultures that some of the signs I've used have not been culturally appropriate. So always try to screen your signs beforehand. Maybe have someone wave goodbye or salute. Have them imitate using tools. So whether that's maybe a hammer or a screwdriver, someone should be able to do this without having a hammer in their hand, or do this to imitate having a screwdriver. If other elements of their exam are good, like they're strong enough to do those, but they just can't figure out how to make the gesture, then you may be dealing with apraxia. And that can be very important for some conditions, and we'll talk about why later on. So the cranial nerves, I know you guys know these by heart now, because they're virtually drilled into you during med school. So cranial nerve 2, looking at the pupils, they were equal, they were round, they were equally reactive to light. And then doing the extraocular eye movements that test cranial nerves 3, 4, and 6, the movements were full in all directions. And not only did I test smooth pursuit, so getting them to follow my finger, but I also tested saccades. Now, saccades are a different type of extraocular eye movement. They use a little bit of a different neural circuitry in our brainstem and midbrain. And you can get a little different information by testing both of those. So saccades is basically saying, I want you to look at X. That's the quick eye movements. It's not a smooth pursuit where you're following something to X, okay? Facial sensation, that's cranial nerve 5, was normal. And we tested all 3 distributions, B1, B2, and B3. And the jaw open midline, so a good motor strength test. Face moved symmetrically, both in the upper and lower divisions. No issue like a Bell's palsy or anything like that. His hearing was normal to conversation. We didn't test it any further than that. And his palate rise was symmetric. And I'm not sure what that other part is, remainder intact, but testing cranial nerve 11, the ways that I typically do it, if I'm not super concerned about that cranial nerve, is I'll test shoulder shrug, you know, test both sides, and test the head turn. So remember, turning your head to the left is using your right sternocleidomastoid, and the right sternocleidomastoid is innervated, and your sternocleidomastoid is innervated by the accessory nerve. And then cranial nerve 12, testing tongue protrusion. It was midline. It wasn't deviated to one side. Sometimes if you're concerned about the strength of the tongue, you can have someone press their tongue into the side of their mouth and push up against the tongue. It's a little difficult to judge tongue weakness, but something to check nonetheless. Now on motor, the motor exam contains 3 main components. You want to test someone's bulk. So look at them, see, does it look appropriate for their age? Are they cachectic? You know, if you think about like the, 98-year-old woman that, not eating much, she's going to look cachectic, so you're making judgments there. And then tone. Tone is an incredibly important thing to test that most people get wrong. And so when you test tone, I usually start with the head actually, but we'll talk about the arms. You want to gently grab someone's arm and move it passively in ways that seem to be unpredictable to the patient, because what you're trying to learn is, does it feel like there's any resistance? And if there is resistance, does a change in velocity seem to influence that resistance? Because in your mind, you want to be thinking, okay, is tone normal or abnormal? So think in your mind sort of a binary algorithm, tone abnormal, normal or abnormal. If it's abnormal, is it velocity dependent or velocity independent? And if it's velocity independent, then you may be dealing with something called rigidity. Most people will throw the word rigidity out there without actually thinking about or knowing what it actually is. So consider whether it's velocity independent or dependent. And in fact, his velocity was independent, his tone was independent. His hypertonia was independent of velocity, and it was more increased, or it was there's greater tone on the right compared to the left. And his strength was normal throughout. So 5 out of 5 strength throughout. On the reflexes, his reflexes were normal, aside from some reduced Achilles reflexes. They were symmetric though. So it was normal, active, and symmetric reflexes throughout. And there were no Babinski signs. So when you applied plantar stimulation, his toes went down on both sides. Testing sensation, I tested both pinprick, which was normal, as well as vibration and proprioceptive sense. And I wonder if anyone on the call might know why I would test pinprick and either vibration or proprioception. Any ideas why I would put both of those things on there? I mean, it's the sensory exam. You can waste a lot of time on that. Why would I test both of those things?
Does it have anything to do with cerebellar function?
No, it has something to do with the neuroanatomy, though.
The spinal tracts?
Yeah, so pinprick is carried through the spinothalamic tract, as well as temperature and what they call crude touch. To this day, I don't really know what crude touch is. It doesn't sound like something we should be doing in the clinic. But vibration and proprioceptive sense and fine touch are carried through the dorsal column. So localization wise, you're going to get different information if one is spared and the other is affected. In this person, it was normal either way, but it's a good way of thinking about it. When you're testing sensation, make sure you get a modality in both of those tracks so that you know what you're doing. And I would say, as far as the dorsal column tracks, putting emphasis on proprioception is important, especially if someone has gait difficulties. Okay, so moving on. Hopefully you're appreciating the fact that it's important to have a system with the neuro exam, because we got through the physical exam in about 30 seconds and we're spending a lot of time here. So I guess I duplicated myself a little bit here. Oh, I know why I did this. So in movement disorders, we have a very different approach, not a very, but a little bit of a different approach to neurologic issues than your general neurologist. Okay, so this is the holy grail for neurology is 3 questions. One is it neurological? So a lot of times you'll get consults as a neurologist for, someone just can't figure it out and they say, oh, maybe it's neurology. You need to be able to say, is this neurological or not? If it's not, then you're kind of done at that point. The second question, though, is where is the problem? So where in the neuroaxis is it? And so from your history, you're starting to build some theories in your mind of where it might be. But then with the neuro exam, this is when you're testing your hypotheses. So yeah, you've got to get your screen in, no doubt. You want to make sure you survey the whole nervous system, but you're also testing hypotheses. Okay, so it's like with the tone. If you think the tones, if your hypothesis is that the tone is increased and that it's consistent with rigidity, well, the tests to prove that are, 1, you feel some resistance against passive movement of a limb, and it's velocity independent. Okay, so make your exam hypothesis driven. You're trying to answer a question, and that question is, where in the nervous system is there a problem? So you're localizing. All right. Only when you figure that out, can you start to say, what is the problem? All right. And then obviously, after you figure out what the problem is, hopefully you can figure out how to treat it. But is it neurological? Where is it? And what is it? So that's how we move through. With movement disorders, we actually started a little different spot. We focus on phenomenology. All right. And so what I mean by phenomenology is there are different movement disorders and movement phenomena. Tremor is one of them. Myoclonus is another one, sort of a brief lightning-like startle. Chorea is another one. So a movement specialist is trained to identify these movement phenomena. And if you identify them incorrectly, they start to send you down the wrong diagnostic path. So this is almost like the equivalent of localization in general neurology. You've got to identify the phenomenon first. So yes, is it neurological? 2, what is the movement phenomenon? And so even though I've been a little bit redundant on this slide compared to the last, we're focusing now on kind of what a movement specialist is really going to be honing in on. So rigidity, I was looking for rigidity. We already told you I found it, and it was in the right arm more than the left, and nothing in the neck or the leg. So that was good. Then tremor. This patient's tremor, we need to try to describe it. And so the way that I would describe it is a low frequency, and that can mean different things, but appeared to be a low frequency. So it was relatively slow. And it had a low amplitude. So there wasn't flapping like this. It was a pretty low amplitude. And it occurred at rest. This is very important. So this is sort of where you divide out so many of your tremor conditions. When does the tremor happen the most? Is it when someone's hand is just sitting there? Is it when they're lying in bed and their arms are next to their side, which is the best time to ask about a rest tremor? If their arms are on an armrest and their hand's just hanging, the hand is hanging and it's shaking, that's a good example of a rest tremor. But, sometimes people are a little bit tense and they might have their arms, kind of a little tense, and you see shaking. Is that a rest tremor? It's kind of hard to know. So remember, your exam should be hypothesis driven. So you need to make sure you've convinced yourself that it's actually a tremor when the limb that's tremoring is at rest. And then there's postural tremors. So, is someone tremoring when they hold their hands out like this or like this? Or maybe if they're holding a cup, or maybe if they're holding a writing utensil. Or what if they're chasing your fingers and it's a kinetic tremor, so an action tremor, and when they get to your fingers, they just can't quite get there. So those are important things that you want to assess. Now, this patient had an interesting finding that when he held his arms out, things looked steady for a few seconds, and then that right arm, or right hand, I should say, started to shake like this, okay? The same one that was shaking at rest, too. And then he had a little bit of a jaw tremor as well, just very mild, and he didn't notice it, nor did his spouse. Now, alternating motion rates are a very important part to a movement specialist exam, and that's helping us to look into really looking for something. Well, we look for cadence. So are things regular, or are they irregular, or irregularly irregular? Sort of the how we describe atrial fibrillation. When a cardiologist says irregularly irregular, bells and whistles go off, and we say, oh, it's AFib. When a neurologist says irregularly irregular, we should be thinking ataxia. So when we're doing, alternating motion rates, whether they're finger taps or opening and closing a hand or rotating the arm or tapping your toes or stomping your feet, we're looking for the regularity of those motions, but we're also looking to see, is there decrement? So do the fingers move like this, which I hope everyone agrees is normal because that's as good as I can do, or are they irregular? I don't know if that's coming across there, but trust me, it's irregular. Or are they kind of dampening? See that? So not nice and full, but then they're sort of dampening and maybe a little bit slower there. So in fact, that's what happened with this patient when he did finger taps and when he did hand grip opening and closing. He had a little difficulty opening and closing it, so it kind of decremented as well. And then his toe tapping did a little bit of the same on the right. Fortunately, everything seemed to be regular, so there was no dysmetria, meaning he was kind of off target. You know, if I was trying to go to my lens, if I was off target, that's what that would look like. And there was no ataxia when I tested the finger to nose, and I did the heel to shin testing. I find that beneficial as well. His walking, which is one part of the exam to never skip, because you can get more information from a 30-second walking than you can get from the rest of the exam a lot of times. First thing that I do when I examine someone's walking is I don't have them walk, I have them stand, because if they're not standing very well, they may not walk very well. So I do the Romberg maneuver, which you're all probably familiar with, where you have someone stand with their feet together, heels and toes together, and they put their arms straight out in front of them, palms up to the ceiling, and close their eyes. That test looks at a lot of different things. We won't go into that at the moment, but if you have questions about it later, we can talk about it. But he was fine with that. His posture was just slightly stooped. So, you know, instead of a nice erect posture, he was just a little bit stooped. So, you know, that gives him a few diagnostic points, but doesn't really count for a whole lot of anything at the moment. Now, his casual gait, and I tell people, walk as briskly as you feel comfortable. And that showed that the cadence of the feet landing on the floor was regular, so it wasn't an ataxic gait. His base, so the distance between his feet, was narrow, so that's good. But his right arm didn't swing as much as it did as the left arm did. And his stride length, so the distance from foot to foot, was reduced a little bit. And when he turned, he didn't pivot. So everyone think about your turns later today when you're walking around, and you probably pivot if you had to move directions pretty quickly. But he had to take steps to make that turn. He was able to walk on his toes, he could walk on his heels, and he could walk in tandem, which is no surprise because he didn't have any weakness on the exam. He didn't have any freezing, so his gait was actually pretty smooth throughout. And when I tested his postural reflexes by pulling on him while he was standing, and we talk about what that means later, he was normal, okay? So let me summarize this, because we went through a lot of things. That was a lot of exams. So we've got a 65-year-old gentleman, and on his exam, and he's got 2 years history of right upper extremity resting tremor, got a little bit of constipation, some erectile dysfunction, and what sounds like dream enactment behavior. And no sense of smell for 10 years. His exam was notable for, and this is really how you should present patients too. His exam was neurologic examination was notable for rigidity in the right upper extremity, slight rigidity maybe in the left upper extremity, as well as a rest tremor in the right arm. And then this other tremor, which we'll talk about later in the right arm, as well as some decrement, perhaps some bradykinesia in the right upper extremity, maybe a little bit in the right lower extremity. And then his gait characteristics, which were the abnormalities were that his stride length was reduced and the right arm swing was reduced as well. So now we have the differential diagnosis. And this is a beast of an acronym. I don't know if anyone's familiar with this, but maybe before we go on, I wonder if anyone wants to throw out some potential diagnoses.
Well, holoprosencephaly.
Holoprosencephaly? What makes you think that?
Well, not in this case, but just as a diagnosis with the Parkinsonism, just plainly. But he might have, I don't know. It doesn't look like anything else because he hasn't been really exposed to anything else, has he? Or maybe not even had any nutritional problems.
It doesn't look like anything else than what?
Well, I shouldn't be really participating because I came in late, but if you put vitamins A, B, C, D, E, F there, are they indicative of maybe?
I'm sorry. This is an acronym.
Okay.
This is an acronym. Yeah, actually, it doesn't really have anything to do with the case. So So
All
what
right.
I described was a 65-year-old gentleman with Parkinsonism. And his Parkinsonism included bradykinesia, a resting tremor, and some rigidity that predominantly involved his right arm, maybe a little bit in the right leg as well. So we're trying to figure out, we've identified phenomenology, we've, identified the other elements on the neural exam that are pertinent. And now we want to try to figure out what are the potential causes of Parkinsonism in a 65-year-old man. So with that in mind, any ideas?
Mm,
Sorry, go ahead.
go ahead.
I was gonna say he did have depression in his as one of his past medical history notes,
Yeah.
right?
Yeah,
If I'm not
good
mistaken.
point. Good. Nope, you're
So-
absolutely right. Yeah.
So that could potentially be a cause of the Parkinsonism like features, because I know depression is also linked with low dopamine levels, and
Mhm.
maybe that could have led to his motor instabilities and lack of motor functioning.
I like
potentially.
that you're connecting the two, but what if it were the other way around? What if the motor symptoms, or whatever's causing the motor symptoms, because that's really the question we're asking,
Mhm.
is also causing the depression?
True. Yeah, that's also
Yeah. Yeah, but no,
It's also
we should think
possible.
about it both ways. That's good. That's good. So let's see here. If I click. All right. So this is what this acronym stands for. You're going to find a bazillion acronyms to help you run through a differential diagnosis. I like this one. When I started med school, and this is what we use at the Mayo Clinic in Florida. When I started med school, it was vitamins like ABC. I think it was vitamins ABC. And we started adding other letters because we started realizing we were missing some things that we needed to put in there. So I'll tell you what they mean. And you're not going to miss things if you go through this. All right. I mean, obviously you have to have a fund of knowledge to be able to put things in these categories, but it's going to give you a system to work through possible causes. And that's really what you need. So the first letter is V, and that's for vascular. When we're thinking about things vascular, let's think about a stroke. Could this be caused by a stroke? Well, one, this guy's got a 2-year history of progressive. That was another thing that I should have mentioned. That's important. 2-year history of progressive illnesses. Strokes aren't progressive, right? They happen now. They're an acute event. That's not what happened with this guy. And you'd be hard pressed to find another vascular insult that would cause these types of symptoms. And I'm not going to go through every one of these in depth because we're going to kind of parse this down pretty quickly. But infectious, infectious seems a little bit odd here. He doesn't have any other kind of constitutional symptoms. Not really fitting with his presentation. Trauma, he didn't give us any history of trauma, so we can kind of take that one off. Ache, what I'm talking about is kind of headache, but we call it ache because it fits in our acronym that way. And he didn't complain of any pain or headache phenomena. Metabolic is something that we should consider. There can be vitamin deficiencies, hormonal imbalances that could cause chronically progressive things. So we want to keep that in our back pocket. Iatrogenic, meaning did the medical community do something to this guy? Did he have a procedure and woke up, with these symptoms? And that's obviously not the case here. Neoplastic, is there a tumor somewhere in the brain that's causing these things? And, it's possible. It's probably not likely, but it is possible. So we wouldn't want to knock that one out altogether. Now, sleep, we could say, well, he's got this sleep disorder, but this is where it gets kind of tricky with neurology is there are some other things that are involved here, but we're trying to find the underlying cause. So my question is all of this caused by an underlying sleep disorder? And I would argue that the answer is no. There's a sleep disorder that may be part of it, but sleep is not causing the whole picture here. So then the ABCDEF is autoimmune. Autoimmune illnesses can present sort of on this time frame. 2 years is a little bit long. We're usually talking about something that's going to be progressive, no doubt, but really on the subacute time course. So we're talking like weeks to months sort of thing. And one of the sort of hallmark autoimmune conditions in neurology that some of you may be aware of is like NMDA receptor encephalitis. If any of you read the book Brain on Fire or seen the movie, if you haven't, you got to check it out. That's a good example of kind of a subacute time course. Behavioral, do we think this is a primary psychiatric disease? And I would argue no. Congenital, well, he started having symptoms at age 63, so it's probably not something that started at birth. Degenerative. Now, degenerative is a wide open field, and we're referring to neurodegenerative conditions. So that might include things like Alzheimer's disease, which this doesn't sound like, Parkinson's disease, which this could be, and many others. So I think we should keep that one on the list. And neurodegenerative diseases typically are going to have the time course of chronic progressive. And I think that fits with this gentleman. So another kind of sort of algorithm to have in your mind is time course and progression. That's going to help you narrow down your diagnosis a lot. Are we dealing with acute, subacute, or chronic? Are we dealing with an improving condition, a static condition, or a progressive condition? And you put those three things together and you can really, really weed out a lot of the things that aren't pertinent here. Electric is referring to a seizure disorder. That doesn't sound like anything that's going on here. And fluid might be something like hydrocephalus or normal pressure hydrocephalus. And, that's a possibility, the latter, normal pressure hydrocephalus. So we can keep that, in our mind as well. But if we think about all these things, the most likely diagnosis that we're dealing with is Parkinson's disease. Because we've got a 65-year-old gentleman with Parkinsonism. It's 2-year history, chronic progressive. It fits with the temporal profile of a Parkinson's disease. But there are some other things that we ought to consider, and at least at the beginning, and that is atypical Parkinsonism. So PD is one of many neurodegenerative diseases, but there are other things that can mimic Parkinson's disease. Does anyone know what some of those are? And Fadi cannot answer this question. Anybody with a shelf coming up? Crickets. All right. Well, let's talk about a few of them. One is progressive supranuclear palsy, and PSP. And there are a few hallmarks that patients may have with PSP. The things we talk about are early falls, which this gentleman didn't have. We talk about like axial midline rigidity, could be in the neck, could be in the trunk. This guy did not have. And abnormalities of extraocular movements, particularly vertical gaze, vertical saccades, in fact, and his were normal. So this doesn't look like PSP. Another one would be multiple system atrophy, and or MSA for short. That one can come in a couple flavors, and one of them may look a lot like Parkinson's disease, but there's usually very profound autonomic impairment in MSA. And so autonomic impairment, did he have any of that? Now, he had some constipation, some erectile dysfunction. Yeah, he had those. His blood pressure was fine, so no real evidence of orthostatic hypotension. So while there was a little bit of autonomic dysfunction, or at least you can make a case that there was, it didn't seem to be a major issue that he was dealing with. It wasn't sort of the main symptom that you were looking at. So I think that's probably less likely at this case. Another one is dementia with Lewy bodies, or Lewy body dementia. That's what Robin Williams had. And this can look a lot like Parkinson's disease, but usually cognition is going to be affected much earlier. And these patients may have rapid fluctuations in their degree of cognition. They may have visual hallucinations. That's one of the hallmarks. And they're going to have Rem sleep behavior disorder. So he did have that, but he didn't have the visual hallucinations, and cognition was normal. Oh, and I should say multiple system atrophy may also have Rem sleep behavior disorder as well. And maybe the last one that I'll mention is cortical basal degeneration. That is similar to PSP, but cognition may be affected. Patients typically have very asymmetric symptoms. So his symptoms were asymmetric, but so that gives him some diagnostic points there. But apraxia is also commonly seen with corticobasal degeneration. So that was one reason why I checked for apraxia in that. But altogether, we're not seeing much in the way of red flags for Parkinson's disease, that would steer us away from that diagnosis. So common things being common, and you guys have probably heard when you hear hoofbeats, you should think horses and not zebras. Common things being common, this is probably Parkinson's disease. Other things we might want to consider are drug-induced Parkinsonism. So there are even medications, some anti-nausea medications, antipsychotic medications that block dopamine receptors. He wasn't on any of those, but that's always something we need to think about in the back of our mind. So those are the big three sort of categories that I would be thinking about with this patient, in whom there really aren't any really unusual characteristics besides those which we could explain by Parkinson's disease.
Hey, Phil, I had just one question.
Yeah.
I know common things are common, but just being the oddball out here, regarding the pesticide, like farmer history, all that, would that be ruled out just by a CBC?
No, definitely wouldn't.
Okay.
No,
Because I know that would cause maybe like some bradykinesia, right? I feel like.
Well, so actually we'll get to that with the risk factors. So risk factors for Parkinson's disease, age is the biggest one. Average age of onset is right around 65, which is why I chose that age. It's more common in males. And if you've got a positive family history, your odds ratio of developing PD goes up pretty significantly. Coffee consumption, interestingly, seems to be a little bit protective. Smoking, I'm not endorsing smoking, but at least in this particular study, which was published not too long ago, smoking seemed to be a little bit protective, as did physical exercise. And dyspepsia, ironically, was a risk factor for Parkinson's disease. Now, exposures, and this is what Fadi was mentioning, have been shown through many studies to be a risk factor for Parkinson's disease, pesticides being one. We don't completely understand the mechanism for that, though, but we're not at the point where we're calling it a separate disease. We're still saying Parkinson's disease, and because we haven't found that exact link. Now, there are some toxins that we've identified, but in general, pesticides, oils, metals, even general anesthesia, we consider it, a potential risk factor. Hard to know what that means as far as cause. Does it, is it someone that was already destined to develop Parkinson's disease and they just happened to develop it earlier? Or maybe, we just don't quite have a good handle on what that relationship really looks like. But, Fadi, we would still call it Parkinson's disease. So in this case, he was a farmer, likely had exposures. We see it so commonly, especially here in the Midwest. We're seeing folks come in that were farmers or still are farmers and developing Parkinson's disease. So what kind of work? Yeah, go ahead.
To cut you off, but just so regarding the pesticide, just regarding like pharmacology education, and tell me if I'm wrong, I believe though, like pesticide induced could be ruled out by prescribing atropine, right? Like if you give them atropine, you can see they get better from the bradykinesia or bradycardia that they have, I feel like. Correct?
Well, so that would be a very specific pesticide that you're referring to, talking specifically about those affecting the cholinergic receptors, the muscarinic receptors. But that in and of itself would not cause all the symptoms that this patient has. So bradykinesia is not a symptom of cholinergic toxicity. Bradykinesia specifically is an abnormality of dopaminergic transmission in the brain. And atropine would not reverse a dopaminergic dysfunction. So remember, atropine's a muscarinic receptor blocker. I think you're thinking about the organophosphates. I'm not mistaken.
I forgot the exact name of it, but I know it's a muscarinic though. Yeah.
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 So yeah, you know, if based on this person's exam, I would think that would be very inappropriate. But if you were seeing other things, other evidence of cholinergic dysfunction, maybe the pupils are abnormal, the blood pressure's off, maybe some sweating difficulties, some flushing, those types of things, then I would be thinking, this doesn't sound like a neurodegenerative disease. This sounds like maybe a toxin exposure. Okay, good question though. Very good question. So the workup for this gentleman, basic lab testing, just looking at his renal function and electrolytes, looking at his liver function, thyroid, hypothyroidism can sometimes cause symptoms that can look sort of Parkinsonian. B12 and B6 and methylmalonic acid, all those were normal in this patient. And his brain MRI was also normal. The radiologist said that there was some mild generalized atrophy, but there were no abnormalities in the brainstem. And some of those atypical Parkinsonian syndromes may have some characteristic changes on MRI, though not all the time. But if you see them, it should steer you towards an atypical. So at this point, there's nothing in his history that would really make you doubt the diagnosis of Parkinson's disease, but we still don't know that it's Parkinson's disease. So how do we figure it out? And I guess this is the summary slide. Yeah, already said that. Okay. So the best way is with a levodopa trial. So we know that Parkinson's disease responds very well to levodopa. And goes under the brand name of Sinemet, and that's because it contains both levodopa and carbidopa. Carbidopa, for those of you in pharmacology, know that it prevents the conversion of levodopa into dopamine before it gets into the brain, whereas, obviously that's where we want it to work. Pure levodopa in the peripheral system, when it's broken down into dopamine, makes people very sick, makes people nauseous. And in fact, when the pharmaceutical companies came up with this combination of drug, they named it Sinemet because of the Latin sin, meaning without, and emit. That's where we get our word for emesis, so without emesis. So maybe one way to remember those drugs. So we start patients on a low dose of levodopa. The easiest formulation to use, and one I would recommend, is the immediate release 25/100 milligram tablets. And actually, this is a little bit misleading here. So I should have called this carbidopa/levodopa, because the 25 refers to carbidopa and the 100 refers to levodopa. So we're talking about 100 milligrams of levodopa. So we'd start that one tablet 3 times a day, and we'd increase by half a tablet every week, with the goal of finding the lowest dose that gives the patient the best effect. Effect on what? You need to know what you're measuring. We would hope that there's improvement in tremor, the bradykinesia, the rigidity, walking better, maybe his voice gets a little bit stronger. And our expectation would be, fortunately, what we found in this gentleman. So 2 months later, I saw him back, and he reported 75 to 80% improvement in his symptoms. The tremor was virtually gone. He was moving faster, more fluid. His wife had even noticed that his face appeared to be more animated, and his family said that it's easier to hear him. So it seemed like his voice got stronger as well. So he responded well to the medication. That's a good indicator that we are actually dealing with Parkinson's disease. Some of the atypical forms don't respond as well to levodopa. So let's say he came back and said, no, I didn't respond at all, or only 20% improvement. Then we might be thinking, we need to watch out for some of those other findings that would point us towards an atypical syndrome. So you might ask, well, okay, I've heard about this thing called deep brain stimulation. Could that, be a treatment for him? And what we know is that levodopa is the most effective and best tolerated, but the most effective and cheapest, but the most effective treatment for Parkinson's disease. Deep brain stimulation can be used in the treatment of Parkinson's disease, but typically not early. There are, of course, exceptions, but the main indications for deep brain stimulation would be if the tremor is resistant to the medication, or if someone's therapeutic window is getting too small. So on too little dose of levodopa, their bradykinesia and the rigidity and the tremor are bad. But if you increase the dose too much, they may be getting side effects. So whether it's dyskinesias, kind of those extra movements that you've probably seen in Michael J. Fox, or maybe it's low blood pressure or nausea or something like that that's keeping you from increasing the dose sufficiently high. Sometimes we can do deep brain stimulation for patients that just have bothersome dyskinesias. So those are things that we would consider if we got to a point where we think we need to escalate therapy. So a lot of information. I'd like to open it up for some questions. And I know I may have gone a little bit over on my time, but I want to make sure everyone's questions get answered.
All right, guys. If anyone has any questions, feel free to ask. I guess since first, that was an amazing presentation, Phil. Thank you so much.
Mm-hmm.
I guess since our crowd is majority medical students, just an oddball question I guess I'll have is, why did you choose neurology?
Well, I first became interested in the nervous system probably in high school. My grandfather had Parkinson's disease, actually, and so I kind of developed a sort of a fascination with how the nervous system could cause such peculiar symptoms. But I wasn't sold on, neurology per se, really until I discovered how intricate the physical exam can be. We live in a day where there's a lot of emphasis on tests, blood tests and images, and yeah, we use those, but there's such an issue of overspending with medical resources, ordering tests that we don't need, ordering tests when we get positive results that we have to explain whether they're true positives or false positives. And it's just not a good way of practicing medicine. And the way I learned to practice medicine was to begin with a very detailed history, to use that history to tailor your exam, and then based on all of those findings together, figure out what your remaining hypotheses are, what your differential diagnosis is, and then use your test to prove or disprove your differential diagnosis. And I found that, the physical exam just in general is amazing, and it's what sets us apart as physicians. Being able to put your hand on a patient and figure out what's wrong is really a skill. It's not something that you can teach a monkey to do. You can teach a monkey to interpret a CBC, but you can't teach them how to examine a patient. And the neurologic examination just takes that to another level. Being able to put your hands on a patient and in a few minutes time, figure out where within their whole body the nervous system has gone wrong. It's the most elaborate electrical circuit there is, and you're just trying to figure out where the break in the circuit is. And so I really fell in love with that idea, and so those things together really steered me towards neurology. I considered neuroradiology, but I wasn't going to get to examine patients. I consider neuropathology because I think that the neuroanatomy is incredibly fascinating. But again, I wanted to be able to put my hands on patients and actually help them. And neurosurgery was a consideration of mine as well. But still, I found that the time that I had or would have as a neurosurgeon was really going to be spent more in the operating room doing the problem solving there, which is fascinating. But for me, I really liked the idea of being able to interact with these patients and be sort of a detective, because that's really what you are, not only as a neurologist, but as a physician. But I just felt like all those things together made neurology stand out to me.
I actually have a question as well. Sorry, didn't mean to interrupt.
No, you're good.
I may have missed that last part, so you may have already addressed this because my audio kind of cut out towards the end. First of all, thank you again for giving us this presentation and presenting the case to us, Dr. Tipton. But I have a question with regards to the differential diagnoses. So in your practice, when you come across a patient, how do you get out of that that kind of hole of being stuck on one particular diagnosis because you see all these things lining up and you feel like you're so sure that it's this, but with everything kind of interlinking with each other nowadays, and there's so many different facets we can look at it from, how do you get yourself out of that pocket of being stuck on one or two specific diagnoses and looking at everything?
Always being aware of your bias, and I think maybe bias isn't the right word, but it's actually kind of a nice analogy to what happens is anchoring your diagnosis. So one of my mentors told me that, once the diagnosis is made and once you stop, questioning the diagnosis, thinking stops. You say diagnose and adios, we're done. We don't need to do anymore. But you should constantly be running through your findings, both pertinent positive and pertinent negative, to question, your hypothesis. It's truly a hypothesis. We don't have a way of diagnosing Parkinson's disease with 100% certainty until the patient goes to autopsy. So it's still a hypothesis. And so you're constantly running through your hypothesis and trying to prove it wrong. So every time you see the patient again, you're asking yourself, is this still behaving, in the case of this patient, like Parkinson's disease? Or is it starting to have a flare of something else? Maybe one of the atypical Parkinsonian syndromes. Is there something that I missed? And so, Parkinson's disease, we didn't really go into it, but it's one of the most complicated diseases there is. And, making sure that you're not missing anything as far as symptoms that are involved can really help steer you toward away from that diagnosis. Some of it is pattern recognition. So, this case, there's no question. Sure, there's question because you can't 100% diagnose someone until they get autopsy, but there's no question. There were absolutely no red flags in the history, but that's not usually real life. Usually there are going to be some loose ends that you're always kind of running through in your mind to say, are we treating this thing right? Now, at the end of the day, we don't have a cure for Parkinson's disease. And we know that these patients respond well to levodopa. And the whole reason why we're all doing this is, first, do no harm, but two, is to help our patients. If they're improving on the medication, then I think that's pretty good proof positive. And the studies would echo that as well. But yes, always questioning your diagnosis is important, not to the point where you drive yourself crazy, but to the point where you're taking the best care of the patient possible. Good question.
Right. So in line with that, I have a second part to that. How do you, with neuro especially, where, you have a lot of psychiatry mixing into that, how do you address the root cause, or be sure enough about the root cause where you're treating one over the other in a way to deter it from progressing worse? How do you, I know that's a kind of a loaded question maybe, but it's
a good question. So in the case of Parkinson's disease, depression is very common, but as you guys all know, and not just because you're med students, but because you're humans, that depression is very common among the general population. So it's not uncommon that we'll see patients' depression also improve when they're on an adequate dose of levodopa. But if I've convinced myself that they're on an adequate dose of levodopa, say their motor symptoms got better, but their depression is still there, then I'm going to treat it like run-of-the-mill depression. Now, we've already done some basic labs to make sure, that someone's not hypothyroid, but, then you treat it like run-of-the-mill depression. And even in some cases with Parkinson's disease, they're going to be on an antidepressant, and that's okay. But making sure that someone's on an adequate dose of levodopa is very important for that. Now, there are other conditions where you may have to ask yourself, is the psychiatric symptom or symptoms a part of a neurologic condition, or is it something separate? And that can get really hard because depression's common, anxiety's common, ADHD is common. I mean, so many of these conditions are so common. You always have to keep in the back of your mind, one, was someone misdiagnosed in the future or in the past? So did they really have depression? Did they really have bipolar disorder? Did they really have schizophrenia? Or is it actually a manifestation of a bigger diagnosis? Go back to what I mentioned earlier with some of the autoimmune illnesses. NMDA receptor encephalitis, those patients can have hallucinations, anxiety, depression, just severe mood swings where they could get blown off. They could get arrested. They could get imprisoned for, behaving bizarrely, which folks with encephalitis often do behave in a bizarre manner, but it's actually due to a neurologic condition. So I always obtain a psychiatric review of history, review of systems as well. You don't have to dig into it too far if you're not getting anything, but always consider that the mind is part of the brain. So excellent question.
Thank you.
Dr. Tipton, would you go back to the slide regarding treatment really quickly?
Yeah, where is it? Let's see. Yeah.
There. So we learned that usually with Parkinson, you start off with carbidopa, levodopa, but then after 3 to 5 years, the effectiveness of that drug combination may not be what it was when it was initially started. Does that have anything to do with how early on in the disease progression you start the medication?
No, and actually that what you just said is old news, in fact.
Okay.
So there was a long, and this was actually before I was in med school or training, we're talking like 80s, 90s, early 2000s. A school of thought that we should save levodopa because we know it works, but it's not going to work longer. All right. So the way to think about it is that levodopa is truly a supplement. Okay. So we all make levodopa. And if anyone's been in biochem recently, you know that dopamine's one enzymatic reaction away from levodopa. Dopa decarboxylase is what it used to be called. And so that's occurring in all of us naturally. In Parkinson's disease, the cells, the dopamine, dopaminergic neurons are degenerating, they're dying. So they're no longer producing enough dopamine. Just like a type 1 diabetic, their pancreatic cells are no longer producing insulin. So they supplement with insulin because their body's no longer making the insulin. So that's what the levodopa is doing. So by definition, if you're just supplementing to get back to sort of homeostatic levels, it should always work, right? As long as the receptors are still there, right? And it does, in fact. But the issue is how it works. So you have to consider that Parkinson's disease is a chronically progressive neurodegenerative illness, meaning, unfortunately, it's a downhill trajectory to the end. Now, it's a slow, a shallow slope. So it's slowly progressive, but it is a downhill slope. So in the first 5-ish years, I usually tell my patients first handful of years because it's, there's not a hard and fast value, but usually the first 5-7 years, patients will experience what's called a a long duration response to levodopa. And that it's really cool because usually no matter when in the day they take their carbidopa, levodopa, they're going to get the response. It's going to last throughout the entire day. They're not feeling it wearing off or anything. And so as long as they're distancing it from meals, which is an important thing in taking the medication, they're going to get good response throughout the day. But as the disease progresses, their response to the medication will shorten, and the overall response begins to approximate the pharmacological properties, pharmacokinetic properties of the medicine itself. Okay. So what that means is the typical patient, once they're kind of beyond the long duration response, because at this person, you know, they came back 2 months later, they're not going to be able to tell you, yeah, I take the medicine and then 30 minutes later it kicks in. They're going to say, you know, just over the course of working up on this medication, my tremors got better. Not really sure when it happened, but it did. But as you get further along, let's say you're seeing a patient and it's their, you know, their fourth consult, they're trying to nail down the diagnosis, and you're starting levodopa for the first time, but they've had symptoms for 5-7 years, whatever. They're further along in the disease course. They may tell you that I take the tablet and my tremor goes better. It gets better in 30 to 60 minutes, something like that. Okay. And, you know, hopefully it's going to last 8 hours. That'd be great. But, you know, more times than not, it's going to be a shorter duration, you know, 5 hours, 4 hours, 3 hours, whatever. But some people think that the way you should remedy that problem is, oh, well, you should just take more tablets, you know, more tablets per dose. You know, you were taking one tablet and it was only lasting you for, say, 4 hours. So why don't we take 2 tablets and we'll get 5-6 hours? It doesn't work that way, because it's all about kind of topping off your dopamine tanks. That's sort of the analogy that I use. And there's a hole in the tank. So it's a matter of how big that hole is. Rather than taking higher doses, you take the doses more frequently. Okay, so if your patient comes in, they're on 3 times a day dosing, they're keeping it away from meals. And this is important because this isn't rocket science. So whether you're going to be a neurologist or family medicine or internal medicine or whatever, if you're seeing these patients, this is something you're really going to have to understand. Patient comes in, they're on, say, levodopa, 2 tablets 3 times a day. You know they're taking it away from meals at least an hour before the beginning or at least 2 hours after the end of meals, because it doesn't absorb if you don't do that. So they're taking it the right way. You've confirmed that they're taking it the right way. You know they've responded to it in the past. And the problem is they're just not getting symptoms resolution from dose to dose. The doses are not connecting. You don't increase the dose, you add doses. And you base that on how long their response is. Right now, we don't have a great biomarker to be able to know how long your response is, how well you're responding. So we have to go on our patient history. So that's why it's really important to have a good dialogue with these patients and their loved ones when they come in for follow-ups to figure out how to tailor the dose. We're not at the point where we're playing checkers and we can kind of see 3 moves ahead, but it's more like checkers. What did I say? Chess. It's not like chess. It's more like checkers. You know, you're kind of responding to what happens with the disease. Okay. Does that make sense?
Yeah, that makes sense. Thank you.
And if you invite me back sometimes, I'll give you a whole talk on treatments for Parkinson's disease, because it's really important. And there's a lot of folks that aren't doing it correctly, unfortunately. So a lot of that goes back to kind of the older days, we can call them olden days now, of sort of levodopa phobia, that, you know, people are going to become resistant or immune, or, you know, it's only going to work for a short period of time. But you got to remember, you're not on a, you know, a flat surface. This thing has a decline. And so you just have to respond to the disease, recognizing that what it does. And so that's why it's really important. And this goes back to your question, Raul, about, you know, knowing that the diagnosis is correct. You got to know how you think they're going to respond to this medication. And if they do, then you know how you need to tailor it moving forward.
Right.
Thank you so much.
Thank you.
Absolutely.
Thank you. Are there any, does anybody have any other last lingering questions?
I actually have another one
Yeah.
that was regarding the epidemiological side of things,
Uh-huh.
where you talked about the things that make it that potentially help
Oh yeah.
treat Parkinson's, right?
Yeah,
Lifestyle.
you're not going to pick up smoking, are you?
No.
Okay, good.
Well, in line with all of that, I know these were speaking of on the aspect of treating Parkinson's, correct? Potentially, I put that in like quotation marks. But what would you say for prevention? Like, what are the current
Oh
studies
yeah.
saying about preventing it? Because I know sometimes it's not really preventable, especially if there's a genetic component. But what, if any, can we do?
This is the $1 trillion question right now. And obviously there are a few non-modifiable risk factors in there. You can't do anything about your age or your sex and really your family history either. So I think really for prevention, the emphasis is on physical activity. There are a lot of good studies actually that have come out looking at the effects of physical activity on Parkinson's disease animal models, particularly mice and rats, as well as what it does for people that already have Parkinson's disease. Unfortunately, there's not as good of data yet as there is in Alzheimer's disease, but I like to draw a lot of parallels. They're both neurodegenerative diseases. They're caused by different proteins, but there are a lot of similarities. And there's a study that looked at patients with Alzheimer's disease that have causative mutations. So, whether it was the APP or presenilin 1 or presenilin 2 mutations, those are deterministic mutations. You're going to develop Alzheimer's disease. And if you have a positive family history, you can look back in your history and see when, your mom or your grandmother or your grandfather, whatever, developed symptoms. And that's usually a pretty good indicator of when you're going to begin developing symptoms. Okay. So you can imagine that provides a really unique patient population to study, because you can look at different factors to see, what did we do to the age of onset? Could we delay it? Or, did some people do something that caused their symptoms to occur earlier? So that's been studied in Alzheimer's disease, not as well studied in Parkinson's disease yet. But they found that 150 minutes per week of aerobic exercise was associated with a 14-year delay in symptom onset for Alzheimer's disease. 14 years. I mean, there's no medication that comes close to that. That's really important, because even though it's not a cure, it suggests that we're doing something to the disease, which we know begins long before symptoms emerge. In the case of Alzheimer's disease, 20, 30 years, you may have amyloid deposition beginning in the brain before you have the slightest hint of a memory issue. So it's the assumption, and I think it's a reasonable one, is that Parkinson's disease acts in the same way, is that the alpha-synuclein deposition, Lewy bodies, are beginning to form long before someone develops motor symptoms, long before, probably even before they develop the non-motor symptoms like constipation or hyposmia. So if we could intervene earlier, obviously we like to change the trajectory of that disease earlier. And so hopefully it would be later onset of disease, or maybe even preventing disease altogether. But this is an area where, research is focused on right now, but we don't have a preventative, but I would say physical activity is protective. And for those that have already developed symptoms of Parkinson's disease, participating in regular aerobic exercise also seems to be associated with a lot of good things, both cognitive, motor, non-motor, mood. So that would be the one that I'd say probably has the biggest chance of being a preventative measure, short of any kind of disease-modifying therapies, which are obviously being studied.
Gotcha. Thank you.
Mm-hmm.
Yeah, to just add to that, I actually had read something about how Muhammad Ali and how his boxing prolonged like his symptom onset as well. It was similar to that.
Yeah.
Yeah, it's certainly possible. I mean, unfortunately, we only had one Muhammad Ali, so if you can't clone one and have a negative control, it's hard to know. But I've even seen it firsthand with my patients, not just with Parkinson's disease, but even some of the atypical Parkinsonian syndromes like MSA. The patients that are, vigorous exercisers, they do better. They do better longer. I mean, to the point where sometimes it can make you, think, do they really have MSA, or is this really just a mild form of Parkinson's disease because they're doing so well? So I don't think the benefits of exercise can be overstated at this point.
Okay. With that being said, if there's no more questions, we'd like to thank Dr. Tipton again for taking time out of his Saturday to spend time with us and give an amazing presentation. Thank you so much.
Absolutely. Thank you, guys. Thanks, everyone, for coming. Y'all have a good afternoon.
You too. Thank you.
Bye.
Bye.